Hello, everyone. Thank you so much for joining us. My name is Lilly Stairs, and I am the founder and principal at Patient Authentic and the vice chair of the board of directors of the American Autoimmune Related Diseases Association. And I'm also a 3-time autoimmune disease patient living with psoriasis, psoriatic arthritis, and Crohn's disease. Thank you all so much for joining us. I'm honored to be moderating this important discussion on behalf of Let My Doctors Decide, a national partnership of leaders across healthcare working in support of a simple goal. Treatment decisions should always be made by patients and trusted healthcare professionals, not insurance companies or pharmacy benefit managers. This discussion will provide insights from healthcare professionals, patients, doctors, office managers, and individual advocates about step therapy, rebate walls, and other barriers to accessing medicines and care broadly. I am a patient and an advocate and look forward to this discussion, particularly from the rheumatology community perspective, as the virtual gathering of the American College of Rheumatology annual meeting is underway. The past several months have reinforced the importance of much needed changes across our healthcare system. We all know that patients with autoimmune diseases, including rheumatology disorders, are at increased risk of severe COVID, and these unnecessary barriers make it more challenging to maintain good health. During the discussion, you'll hear about national efforts to raise awareness about the complex contracting relationships that are interfering with patient access, the importance of transparency, and adopting changes that put patients first, the foundation of the Let My Doctors Decide patient-centered contracting principles. This stepped-up call to action for adoption of these principles will help achieve change and much-needed improvements to our system, lowering costs, supporting patient-provider relationships, and ensuring healthcare coverage more closely aligns with patient-focused goals to promote affordability and manage overall costs. We believe that the moment has arrived for decision makers in healthcare and government at all levels to adopt these principles that build upon the clinician-patient relationship by focusing coverage policies on empowering provider decision-making, promoting access, and addressing affordability. Let me take a moment to introduce our distinguished panel of experts. Dr. Harry Gewanter is a retired pediatric rheumatologist where he practiced for years in Richmond, Virginia. He remains a tireless advocate for the rheumatology community and has also been active in the area of biologic and biosimilar drugs, serving as the immediate past chair of the Alliance for Safe Biologic Medicines. Dr. Gewanter is a well-known, frequently sought-after thought leader, and he has authored a variety of articles and op-eds and has testified numerous times about patient wellness issues and access barriers. Dr. Robert Levin is in private practice, specializing in rheumatology, located in Clearwater, Florida since 1989. He is an associate affiliate professor of medicine at the University of South Florida. He serves as the immediate past president of the Florida Society of Rheumatology and the president of the Alliance for Transparent and Affordable Prescriptions. He is a member of the board of directors of the Coalition of State Rheumatology Organizations in the American Rheumatology and Internal Medicine. He is involved in clinical research as a principal investigator in the areas of systemic lupus, Sjogren's syndrome, novel treatments for osteoarthritis, and novel treatments for rheumatoid arthritis, psoriatic arthritis, chronic pain, gout, and osteoporosis. Dr. Betsy Kirchner is a doctor of nursing practice at the Cleveland Clinic in the Department of Rheumatic and Immunologic Diseases. She is board certified in rheumatology nursing and is co-president of RHAPP, the Rheumatology Advanced Practice Providers. Dr. Andrea Zlatkus is a practice manager at County Rheumatology Practice in Westchester, Pennsylvania, where the staff also includes patient advocates who fight for physicians and patients' treatment choice in all aspects of insurance, education, and affordability. Andrea is active in NORM, the National Organization of Rheumatology Management, where she recently served as president and is active on the education and advocacy committees. Now we are going to move into opening statements from our panelists. Dr. Harry Gewanter, let me start with you first. As an autoimmune patient and advocate, I'm accustomed, as I know you are, to running into this maze of confusing barriers that disadvantage patients and prevent us from getting the medicines that healthcare professionals recommend. As a doctor and member of the advisory task force of Let My Doctors Decide, a national campaign hosted by ARDA that is dedicated to raising awareness and promoting reform of step therapy, how are these barriers impacting your ability to provide the best care for your patients and in the long run impact their road to health and wellness?
Well, Lily, first of all, I want to thank ARDA and everyone for inviting me to be part of this panel. It's truly an honor to be with my colleagues here and talk about these important issues. And to me, I think it would be helpful as we start off with this to put some of this in context, because a lot of the issues that and the barriers that we're facing now started in the 1980s when HMOs first came into effect as presumably a way to reduce healthcare costs. And the idea was that by regulating and starting to limit the number of services that patients provided and were provided, and that healthcare providers prescribed, we'd be able to reduce costs. And the idea was that with less output, there'd be less cost expenditures. And this assumption has continued since that time and has expanded into the world of prior authorization, step therapy, copay accumulators, and everything else. And in fact, no one has really tested that assumption to say, if you have more regulation and more oversight and more limitations on the providers and patients, that actually saves money. We haven't seen the prices or the healthcare costs for our nation go down, for sure. We have seen the administrative costs within the systems go up. It's up to about 30% right now. And all of the healthcare providers have been given the accountability for the costs in our healthcare system without the responsibility or the data to be able to adequately make appropriate decisions. There seems to be an assumption, and this comes from the business world, that more output means more profit, and therefore physicians are going to behave in a way similar to a store manager, that you want to sell more product so you can make more money. That's not how we think, and that's not our oaths nor our goal when we're with the patient. We want to certainly help our patients spend as little money as possible, but we want them to get better. And having prior authorization, step therapies, copay accumulators, and all the other barriers and other delays that are built into the system really may decrease output, but it does not equal better outcomes. And really what we're talking about here are better outcomes. So I think part of what we need to do as a society and is to restore the physician, the provider, and patient relationship. That's about the only thing that has stayed the same since the 1980s. If you had someone frozen back then and then brought them back now and asked, they had to deal with the system, the time they spent with their healthcare provider would be the only thing that's the same, except they wouldn't have as much time because we now have productivity standards and everything else. So I think I'm looking forward to this discussion as we talk about what's been put in place to interfere with our relationship and helping our patients improve.
Thank you so much, Dr. Kirchner. Sorry, Dr. Gewanter. Now we're moving on to Dr. Kirchner. Dr. Kirchner, so we know you have faced similar barriers as an advanced practice provider as you work closely with patients and prescribe their medications. What changes do you think are necessary so that patients can obtain the information and resources that they need and to get access to the treatments that you prescribe?
Just like Dr. Gewanter, I would first of all like to thank you for inviting advanced practice providers to this table. And I'd also, like Dr. Gewanter, like to put your question into a little bit of context, because I've been a nurse practitioner in rheumatology for over 20 years, and I am not sure the general public, I know patients who are intimately involved with the process like you are, understand how much the pharmacy benefit managers and insurance companies intrude onto our relationships, but I'm not sure the general public really appreciates that. And it's tough to explain, but it's almost like having a third person sitting between me and my patient. And every time I want to say something about treatment options or any topic related to therapy or even prognosis, there's this entity sort of in between us saying, you can't do that, or that's going to take weeks to get approved, or I don't care how sick this patient is, you have to try a medication that isn't proven to work as fast or as well or as safely because I said so. So I really, honestly, in my heart, believe that the patient-provider relationship is sacred. And I feel so privileged to be part of my patients' lives. And I resent that my patients and I are viewed as sources of profits to be squeezed and manipulated to maximum economic benefit rather than human beings just trying to help people live their best lives. Now, that's the context. To answer your question, how can we make this easier for patients? One more step back. The question illustrates one of the fundamental problems with the system as it stands today. Why should the burden be on the patient to navigate barriers that are put in place for the profit of others? We need to ask ourselves as a specialty in rheumatology and more broadly as a nation, how much of this are we willing to put up with? If my patient and I decide on the best treatment based on her diagnosis, her lifestyle, her comorbidities, her past history, or past surgical history, allergies, everything else that goes into this important decision, the burden should really be on her insurance company that she is paying to get that medication to her. It shouldn't be on the patient to navigate hurdles and jump through hoops to get the medication that we've decided on. So if we keep bending over backwards and saying, go to this website, find the best price, then go to this website and find a copay card. And then if you're Medicare Part D, make sure you sign up for a new program next year because the formulary is going to change. Where's the incentive for the insurance companies and the PBMs to change if we're having the patients and the office managers and the providers do all the work? Now, I still haven't answered your question. So I think, honestly, one of the best things to happen to rheumatology since DMARDs is clinical pharmacists. I know many practices can't afford to have clinical pharmacists on staff, but the ones that do, they are an invaluable resource. It's one point of contact for patients. They can answer questions about side effects, about the alternatives. Sometimes it just comes down to, I'm done fighting. I'm going to give you what we can get. And, our clinical pharmacists can answer all those questions, can help with the prior authorization process. They can realize, they can help with every step of the way, really. So to finally answer your question, Lily, getting a whole team involved, and if that team involves a clinical pharmacist, all the better, is probably the best thing we can do for our patients instead of dumping this all on them to give them the support they need from our end of things.
Thank you so much, Dr. Kirchner. I appreciate your insight. Dr. Levin, I want to pass the ball over to you now and have you speak a bit more to the complexities of contracts, specifically related to the middleman and how this can impact patient care.
Sure. Well, thank you so much. And like the others who have spoken before me, I really want to thank ARDA for the opportunity to be on this panel. So I want to talk a little about who ATAP is, or the Alliance for Transparent and Affordable Prescriptions. Our group was founded in 2017, and we're now composed of 26 member organizations. And really, the genesis was that the Coalition of State Rheumatology Organizations, the CSRO, had a meeting with a past PBM employee. And the disgust in that presentation led to the CSRO bringing together other members of our community, and that includes NORM, it includes many of our state rheumatology societies, includes the ACR and a number of other specialties as well as patient organizations, to form ATAP to combat the PBMs and what they were doing in terms of their limiting access to care and, frankly, greed. So we have a website, atapadvocates.com, where I've posted op-eds, Harry's had posted op-eds. Other members have posted other pieces, and so we are active. And really, our goals are to educate on the system and how awful it is for patients and how it really limits access to care, and also to promote legislation and other regulatory changes that will make the system hopefully work better in the future. So in terms of contracting and rebate wall issues, I think we need to look at it that insurance companies and PBMs, or pharmacy benefit managers, have unprecedented control over what medicines are prescribed, especially advanced therapies such as biologic or the more expensive therapies that we use to treat our complex autoimmune and inflammatory diseases. And so these decisions, or formulary construction, which is basically which drugs are preferred, which ones are not preferred, and which ones aren't covered, these are not based on what's best for the patient, what's safest, what's most effective, what fits for our patient based on all the factors that have been stated by our other panelists, but rather what's most profitable to the PBM and to the insurer based on a hidden matrix of rebates and fees. So what are rebates and fees? So they're nothing more than a simple kickback. These are kickbacks from the manufacturers to the decision makers, the PBMs, for access to the market. And so, basically the company that can provide the biggest bundle of cash to the PBM is the one that's going to get their drug as preferred, and that is going to be required to be used. And so this is really, if you think about it, the genesis of step therapy and prior authorization and all of these other utilization management tools comes back to the rebate system. So the rebate system, so how did the PBMs get here? The PBMs sit in the middle of really a whole host of folks that are involved in delivering a drug, the right drug, to our patient. And so we've got the pharmaceutical manufacturers, we have pharmacies, both regular pharmacies and specialty pharmacies. We obviously have the patients and the providers. There are wholesales, there are health plans and PBMs. And to make it more complicated, there have been a ton of mergers now between the PBMs and the health plans, making them more of a behemoth and difficult to manage. So as I said, the current system rewards these higher rebates or the list prices and gives specific medicines preferred placement on the formulary. And so this is not based on safety, efficacy, or anything like that. It's based on which one's most profitable, as I have said. So this is really where the majority of the access and affordability problems arise that patients face. Because if you think about it, when a pharmaceutical manufacturer has to pay a gargantuan rebate to this PBM who's controlling access to the therapy, they have to pay a bundle of money. Well, this bundle of money, turns out, has to come from the list price. And so it turns out the higher the list price is for a drug, the more money there is in the system to pay as this rebate to get the drug access to the market. And that's really the key for the manufacturers. So you have this setup where you're not getting the access to what might be the best drug for the patient based on their clinical situation and based on safety and efficacy data. It's based on just profitability to the middleman and to the insurer who may be in business together and in bed together. So you asked me about rebate walls, and I can just define that really quickly to conclude. Maybe we can get into more of this into this discussion. So let's say hypothetically that one of the manufacturers has a very big market share. Market share is key because the more market share they have, the more prescriptions that will go out and the bigger the rebate that will be able to be paid but from the manufacturer, because the rebates are paid based on the number of units of drug that are sold. So the rebate wall is essentially that if a manufacturer has enough clout, the manufacturer can contract with the PBM the one that has all of this market share and exclude the others. And so drugs that are innovative, for example, that are new to the market that have no access, and their manufacturer doesn't have this access already with another product, they may be excluded and not be able to even give away their drug for free without, and let alone that the drug had billions of dollars of R&D to make up. And also they, you know, despite the prices of drugs going up lately, a couple of our pharmaceutical companies have noted decreased profitability per unit sold despite significant double-digit inflation in the price of their drugs. Where is this money going? It's going to the middleman. So the system is so convoluted, so complex, that it's very difficult to understand. But it's that way for a purpose. And the purpose is, if you keep this in mind, follow the money. The money is going to the PBMs and to the insurers, and the patients end up paying their percentage copayment off of that increasing list price, which is really just a big detriment to access to care. I'll stop there.
No, Dr. Levin, thank you so much for sharing that, and really interesting. I feel like I'm going through all of this right now. I just got a note from my insurance that it's going to be going up from about a $680 monthly premium to $800 something next year a month for a premium. And, you know, so you see so much money that's pouring into these insurance companies. And we know that from COVID this year, we're seeing some of them have record numbers that they've hit. Because there are not as many people going to the doctors, but they're still hiking up prices. And so, you know, thank you for sharing that and sort of explaining some of the intricacies. I think it's really helpful for our audience to understand. And so now I want to head over to Andrea and talk to you a little bit about your experience as an office manager, because I know, and so personally appreciate the countless hours that you spend on the phone with insurance companies and others on coverage denials and preferred pharmacy issues, prior authorization requests, and other unnecessary requirements to advocate for your patients. So what do you think can be done to increase transparency and make this easier for managers like yourself so that you can spend more time with patients to improve health and wellness versus wrangling with the burdensome red tape?
So first, thank you, Lily, and thank you for asking me to join this panel. One of the things that I truly believe is that once my doctors make that decision with the patients on the treatment that's right for them, we try to make that happen. And so many times the PBMs or those that are making us do the prior auths put that barrier in front of us. And it's my staff's job to knock down those barriers and really honor that decision that the doctors do. So I'm really proud to be part of it, let my doctors decide, because it's been my philosophy. I've been in rheumatology for 23 years. And when I first started, we would say, the doctors say, I want this treatment. We'd call the insurance company, we get the patient on treatment. It's not so easy now. And we tend to be sometimes the bad guys, right? So, patients, we call them and we say, okay, we're going to put you on this treatment plan. And then we're calling them saying, okay, we aren't able to do that, or there's a delay because now we have to appeal the decision that your insurance company has denied our request. And our goal is to make that decision happen. So we will go ahead and appeal that decision and try to fight for our patients and and protect that doctor's decision with that patient. So some of the things that we do is, the many appeals, so you said hours on the phone when we get that denial, talking to the insurance companies, talking to the patients. Sometimes we have to get the HR departments involved and trying to understand all the complexities. So one of the things I have here is that changes are coming at us fast and furious. So what could help a practice is consistency. There's no consistency whether you're talking to an Aetna plan, and that Aetna plan has so many different plans underneath of it with all different guidelines and all different rules. It's different if you're talking to a self-insured plan, or sometimes they're called ERISA plans. So where your HR department has designed their own plan, and now you're following different guidelines of prior authorization, step therapies, what we have to do, which is totally different than the plan next door because they bought a different formulary and different tiers. So we are constantly trying to navigate that. My practice is very lucky because we do have some great patient advocates that truly care about the patients and will go and take that extra mile to fight for the patient and for that decision that they made. I know I was on a call with some practice managers and they said sometimes they just feel so beaten down that they take the path of least resistance. And that's what we don't want. We don't want just to give in to what the payer demands. They're not the doctor. They don't know our patients. And we want to preserve that relationship and that decision that the doctors had made. So I think some consistency and understanding of the rules and easier appeal process. I think we need some laws to help fight these accumulator plans. The patients are really struggling. We do a lot of our medications on the medical benefit side. And now we're being pushed more and more to the pharmacy side where all the cost accumulators are, which in the end of the day, all the cost shifting is going to the patient. They say that it's really helping the healthcare system. It's just helping the middleman. It's helping the insurers. It's not helping the patients. We're not seeing our premiums go down, as you said. You know, my premium goes up every single year. My deductible goes up every single year. I want some specialty meds and as a patient myself. And every year, you know, we're in October, end of October, I still have not met my deductible because my medication doesn't go towards my deductible. So everything's been out of pocket. So we're paying high premiums, but yet we're faced with higher costs as a patient as well. So consistency is the biggest thing, and understanding the rules and how do we get all of those rules to the forefront is really big.
Thank you, Andrea. And again, thank you for the work that you do. It's it helps lift some of the burden off of patients, which is huge. We do a lot of our own phone calls, but I know that having the office managers does reduce a lot of that burden. So thank you for that. So now, and this can get a little dicey because I never know who wants to jump in. I don't have targeted questions for all of you, but I do have some questions that I just want to open up more broadly. So, you know, a few of you can jump in and speak and we'll just take turns. But my next question is, what role can policymakers play in shining a spotlight on insurer practices, particularly when it comes to standing in the way of patients getting access to their medications through their health plan?
I'll start off. You know, Virginia was one of the, in the last 2 years, we've passed legislation both to limit step therapy and copay accumulators. And we're actually the first state to limit copay accumulators. The downside, of course, is they don't count for ERISA plans. And so it's only, you know, 30 to 40% of the insurance plans in Virginia. This came about through a strong coalition of patient and physician groups working together to educate our legislators about what this was all about, and having a legislator who faced these problems in his own family. His wife had psoriasis and had to go through step therapy and could not get the medications that were prescribed, and he basically got pissed off and led the charge on this. On the other hand, trying to explain to legislators who don't know these intricacies about how this is being played, and then having to have the insurance lobbyists just say, well, your premiums are going to go up. When have your premiums not gone up? And, you know, if you think about it, you know, the health insurance industry is the only service industry we pay to give us a hard time. And it's hard for them to lose when they make up the rules. And that's the situation we're in. So having legislators understand that. And I think the second part that we really need to work on with legislators is once they've passed these laws and they go, oh boy, we did it, is we need to continue to have them deal with the regulatory folks, you know, the Bureau of Insurance or whoever in the state, to ensure that these things are implemented and that the payers are not finding their own little loopholes here and there by changing the name of a rebate to a fee or whatever, you know, that way. So they play an important role in illuminating everything. but that's just the beginning in trying to have these problems addressed.
And
Sorry, jump in here. Just wanted to say that you have been a leader in state policy on these issues in Virginia, and a number of other states have passed legislation on a lot of these obstacles, including step therapy, prior authorization, and accumulators. The thing is that you've highlighted is a lot of this action is in the states, and that's where it seems like it's a lot easier to get something done in a state, and by no means is it easy. I'm in Florida, and we've had a step therapy bill up for the last 6 years that hasn't passed. So the states are where the action is, and you mentioned ERISA plans. There is a Supreme Court case that ATAP filed an amicus brief on regarding, it's called Rutledge versus PCMA. And PCMA is the lobbying organization for the PBMs. And so basically what this law intended to do, which was then overturned by the appeals court and now has been challenged in front of the Supreme Court, is it would allow state law to allow the ERISA plans to come under state regulation, state law, rather than being exempt from it. The PCMA group wants that to stay intact so that state laws don't apply and the PBMs can run amok. But bottom line is that this is an important protection, and hopefully when the Supreme Court comes out with a decision, it'll be favorable for us. In any event, you highlighted the states, and I think it's really important. There are federal things that are going on as well. And so really, I think that some of this has to do with rebates and rebate walls. And, bottom line is that years ago, back in the early 2000s, the Federal Trade Commission basically granted a safe harbor to the insurance industry and the PBMs. And there is some rumbling that perhaps the FTC will take this up again and remove and attempt to remove this safe harbor for them, because basically they've made a safe harbor for a kickback scheme, which should be illegal. So I think that the Federal Trade Commission is a big deal, and then there's also federal legislation that's looked into some of this. But in the current political climate, really, it's very hard to get any bandwidth for our issues when nobody seems to want to work with the other side to get anything done that's good for patients and good for the practice of medicine in general. So I'll leave it at that. But there are federal initiatives that are being done. Also, there are executive orders, good and bad, that have come out regarding our issues as well.
Thank you.
Also,
go ahead, Andrea. Go ahead.
As I've had the opportunity to talk to legislators, and the thing that surprised me the most was we need to educate them. They don't always know when we talk about pharmacy benefits versus medical benefits, Part B, Part D. They truly don't understand all the intricacies themselves. So when we go in front of them, we've really got to educate them on how it works, because I might go in and say, behalf of my patients, behalf of my practice, and then the PBMs go in after me and they shine this glorious picture of how wonderful they are and everything they're doing to protect patients. And then somebody else goes in. They truly don't understand that whole system. So part of it is basic understanding and education, especially now with the election. You're going to have some new legislators there that we have to educate both at the state and the federal level. And that's something that we have to take the time to do.
Thanks so much all for your insight on that question. So important because that's really where we move the needle.
Please, I'd just add that, to Dr. Levin's statement that there is federal legislation, again, to improve step therapy that's been introduced in both the House and the Senate. Representative Ruiz of California introduced it in the House, and Senators Murkowski, Jones, and Cassidy introduced it in the Senate. it continues to gain strength, and while it's not going to pass this session of Congress, I think we've got a lot of confidence it's going to go through in the next session, and many patient groups as well as professional groups are pushing for this as well. And I think that that's something that all of us as rheumatologists, as physicians, and the fact is we're all patients at the same time. We all need to tell our legislators to pass this bill and let's get over this hurdle.
Thank you, Dr. Gewanter, and thanks all for your response on that. So I'd like to talk a little bit about what happens at the pharmacy counter. So I know from personal experience that as patients, we don't frequently know what's really driving costs, if we're getting the benefit of discounted prices, and the confusing nature of these rebate walls. And so what changes are necessary to ensure that individual patients are getting these discounts and rebates that are provided to health insurers and pharmacy benefit managers?
If you don't mind, I'll start with that one.
Sure.
The bottom line is that for most drug plans, pharmacy benefits, and that's what you would get at the pharmacy counter. Patients are paying for specialty medicines a percentage of the price. The question is, what price? Is it the full list price, or is it the discounted price that the PBM is paying? And almost uniformly, patients are paying their percentage off the list price. And to say that the rebates and fees might be only a few percent, when you add up all of the fees and all of the rebates, these can be 50% or more off the list price of the drug. So the patients, let's say their copayment is 20% off a drug that's lists at $2,000 a month, but there's a 50% rebate, discount, and fee. So the net price is $1,000. So if it's 20%, the patient will be paying $400 for a month for that drug. And if it's 20% off the list, or if it's 20% off the rebated price, the net price, then they're only paying $200. That's a huge difference. And some of our list prices on biologic drugs are in the $6,000 to $8,000 to $9,000 a month category. These numbers are astronomical and unaffordable for the vast majority of patients that I see. And so there have to be ways that we can protect our patients and get the patients at least to take advantage of the negotiated discounted price that the preferred price that the PBM is getting. It's inexcusable.
Yeah, I couldn't agree more. And I think my biologic probably clocks in as one of the most expensive at $20,000 every 2 months, or it's over 20 now. So, I mean, it's just, how can anyone, even who's in a very high income bracket, sustain that? You can't. So you're right, absolutely right. We need to be ensuring that patients are getting some of these breaks. Does anyone else want to comment?
I think one of the other, one of my friends once said it's bad to be interesting to doctors. And so an interesting fact is that if you look at your copays for your medical services, it's based on the negotiated price. When you look at it for pharmacy services, it's based on the list price. And so there's, to me, there's no reason why we can't make that, the same. And part of the reason why is, in fact, that nobody outside the PBM knows what the actual negotiated price is. Even the companies and the insurers who are buying this product don't know what the PBM has ultimately, negotiated for, and they're just taking everybody's word for it. And so I think that we all talk about transparency, but the other side is people say, well, we need a free market so people can make appropriate financial decisions. If you don't have the pricing data, you can't make an appropriate decision. I can't decide on what to prescribe if I don't know how much everything's going to cost, and that's all allegedly proprietary. And the patient doesn't know nor does the person who is buying the plan. So I think one of the things that would be very helpful is if PBMs and insurers were forced to have fiduciary responsibility to the patients, and therefore be responsible for ensuring that the best price is going to them, rather than us just having to take everybody's word for it.
Harry, one of the points that I just would like to chime in on, I'll be brief, is that we don't have a free market. I mean, the point is that if we had a free market, then maybe some of this obscurity or obtuseness would be okay. But we don't have a free market. It's a totally manipulated market. And for that reason, we need to shed some light on what is exactly going on for the good of the whole system. I think if you shed light on this, you'd see where the major corruption is occurring.
And I think we also got to keep in mind that we're dealing with chronic conditions, right? So it's not oncology where hopefully you treat them and you cure them. We're not curing patients. We're managing their disease. We're not at that stage. So when we're talking about these big ticket dollars, you said $20,000 every 2 months for your treatment, that can go on for many, many years. It's unsustainable. And sometimes I think the insurance company says, well, we have them for this calendar year, maybe next calendar year, there'll be another insurance company's problem. They'll get another job or they'll move on. We got to manage these patients and care for them as we have them now, because if they skip their treatments, and you all know, if we skip treatments and they stop, they flare, they're unable to work, they go back into the hospital, and it does not help the healthcare system at all.
Absolutely. No, I couldn't agree more. And that's exactly what I always talk about, is that yes, my drug is $20,000 every 2 months. But the alternative is when I was hospitalized for 2 weeks with bleeding ulcers in my small intestine from Crohn's disease and arthritis so bad that I couldn't walk. That hospital bill was $200,000 for the course of 2 weeks, where I'm not a contributing member to society. And I'm versus now I have my own company and I'm functioning and I'm in full remission. I mean, you have to look at the quality of life and the value there. And so I think that, we really need to shift towards value-based care as well, but I guess that's a whole other discussion. Okay. So I'd like to talk a little bit more about best practices for healthcare providers and patients when, having these types of conversations and prescribing medications. Is there a way that doctors and patients can team up to try to ensure that patients are getting the treatment that they need? And Dr. Kirchner, I'd like to pass that question to you.
Thanks, Lily. I think education, every chance we get is the most important thing we can do. I have numerous times had patients assume that the providers, the prescribers, get some sort of cut of their drug price. They say, I saw the price of my drug, is it so expensive because, you're getting, a kickback, or do you get paid for every prescription you write? And they really don't know. And luckily my patients, I've known many of them 20 years, they're open with this conversation, but how many aren't open? How many just assume that we're part of this, whole scheme? So I think educating patients, many patients would like to get involved in things like, going to their state or national capital for awareness days. I participated in the lupus awareness day at the U.S. Capitol many years ago, and it was enlightening. But it was the patients who were there that had the biggest impact on the legislators. So I think just the sort of everyday incorporating into the conversation, we're going to run into some trouble with your insurance company. This is the best drug that we've decided together. We're going to have some problems. I just want you to know that, I want you to have the medicine and you want you to have the medicine. So if you're not getting the medicine, it's not because of me and you, it's because somebody else is interfering in this relationship. And then, eventually there will be enough voices, hopefully, with, groups like ATAP to really affect some meaningful change. But it's going to take, from every part of this problem. Everyone has to sort of pitch in, patients, providers, office managers, and really say we've had enough and raise awareness and get some of these, shadowy deals out into public. It's public knowledge, and it should be that, a drug company serves me a tuna fish sandwich at a talk, and it's on a national website under the Sunshine Act, but, somehow all these other shady dealings are hidden. So it's shining a light and getting everybody's voices heard.
Thank you so much, Dr. Kirchner. I think that was a perfect answer. And so I'd like to wrap up here and close out, with one more question before we close out, and we have only got a couple minutes left, but I'd like to talk a little bit about COVID. So many patients are looking to copay assistance programs to help pay for their medicines. However, there's a pattern of policy shifts that are making it more difficult for the most vulnerable patients to get the assistance they need in order to afford their prescriptions. So what is needed to ensure these programs continue, especially in today's challenging COVID-19 environment?
I think one of the things I look at when we talk to our patients is to be open about where their insurance situation stands, right? Because we have so many patients that have lost their jobs, have lost their insurance, and we want to be able to keep them on therapy, and we want to work with them. So one of the things is having that open communication with our patients so that they feel that they can tell us what's going on. As a practice, my staff will do everything they can to keep those patients on therapy. We take advantage of any type of pharmaceutical companies that have assistance for patients that have lost their insurance during COVID. And we've seen it, and we've been able to get them help to keep them on therapy.
I think one of the other things that is helpful that I always recommend for patients when they're in these situations is for them to call their legislators, both state and federal, directly. We don't think about legislators as being our hired help, but they are. We're paying them and they're working for us, even though they don't seem to remember that most of the time. And so that calling them and saying, what are you going to do about it? Creates a situation where they can't say they don't know it's a problem. And if they know that if they don't take care of a constituent, that constituent's going to tell at least 10 other people that what a lousy legislator they are, and they don't take care of their patients. So I think that is one of the other things that is helpful in terms of trying to get this going. And this is, COVID is shining a light on everything. COVID isn't changing the scenarios of what's going on. It's just, made it clearer and crystallized the problems that exist.
Definitely. I love that answer that our legislators are working for us. I'm going to remember that one, and I'm going to share it when I'm doing advocacy trainings because it's so true. And I think we forget that often. So I think we'll close out with that. We're almost at the top of the hour here. So thank you so much, Dr. Gewanter, Dr. Levin, Dr. Kirchner, and Andrea Zlatkus for this incredibly informative and insightful discussion as part of our Let My Doctors Decide campaign. We invite you to visit our website and tour our virtual exhibit, Escape the System, that debuted last year at ACR. This year, you can visit Let My Doctors Decide virtually and see how we've reimagined the system and the tools and steps that you can take, as well as information about our patient-centered contracting principles and an opportunity to support our call to action. We look forward to working with all key stakeholders to embrace and advance the patient-centered contracting principles that put patients first and improve health, lower costs, and help ensure that decisions are left up to patients and doctors. Thank you.